Good day, everyone. It's me, Prathalan, a clinical psychologist and interpersonal therapist. So, currently, we have been talking about the history taking and the report writing. So, today in this class, we are going to cover two topics. The first one is how to write a proper diagnosis as per the decorum of DSM 5 TR, right? And the second thing would be the mental status examination. In our previous lectures, let's just summarize them first. All right. The first thing we did was to understand what actually clinical interview is, what are the prior demands about conducting a clinical interview. Being a therapist, being a clinical psychologist, what are the expectations you have to meet before presenter and before working as clinical psychologist in the clinical setting, right? We talked about different tendencies that can actually harbor in a person and destroy the clinical setting as a therapist, right? We also talked about different kind of scenarios where different kind of patients and the case studies where we discussed that how those particular situation can actually make yourself realize that how to work in those particular situations. Maybe books are not so capable enough to do that for you, right? So we talked about our personal grooming, our personal skills that should be incorporated in ourselves prior to working in those particular settings. All right. We also talked about different styles, different patterns to be presented in case of conducting any psychological sessions, right? So prior to that, we also discussed that what are the basic strategies you can work on while conducting a clinical interview, while conducting a history taking or any kind of therapeutic session, at least, where you have to work on different essential strategies over the period of time to actually access a very certain, a very understandable and affirmative information from the client to help you out to understand the complete picture. All right. So we also talked about how to grab that information from the client. All right. So even we also had studied that how, in case if the patient is very much resistant or having a very silent treatment towards you, then how you can use that particular situation in favor of your own self. All right. We also discussed how to actually manage that silence and the resistance as well in that particular settings, right? Then after that, we also talked about presenting complaints, right? We talked about the problem client is actually visiting for, right? We talked about the types that is the presenting problem and the concerning problem, right? We talked about those particular risk factors that actually make you realize over the period of time that these should be resolved first. These are those particular issues, these are those particular problems that needs to be actually worked on first, right? So we actually gone through all that things. And now we in our previous lecture we talked about the whole complete systematic and standardized picture of history taking and why is it so important. We also discussed about that, right? So today, after taking the complete history, the first things that come in your mind, being a therapist, being a clinical psychologist, or any other medical practitioner, is that what would be the relative diagnosis over the period of time when you have gone through a lot of practice. You would be like, oh, all right, these are those particular problems that are actually needs to be addressed in the complete DSM-5 TR. Are you going to apply all the assessments on him? Obviously no, right? The complete standardized process of the history taking made you realize that actually this is the direction I have to work on. How did you get that direction? First of all, by his appearance. by his problem, right? Then after taking the complete history, then after observing him completely, right? So that complete standardized manner made you realize that problem can be like this sort of, right? So that sort of problem from all those thousands or maybe more than that, you got certain hints of the problem apart, right? Those are those chosen problems that have some kind of similarity with the current issue, right? So that extract problems are tentative diagnosis, all right? Or you can even say those are the primitive diagnosis because after that, you are going to perform certain assessments to realize, all right, what is the most appropriate tentative diagnosis, right? What is the most appropriate matchable thing to say about this kind of problem? What actually patient can be experiencing, right? So the tentative diagnosis can be one, two, or three kind of disorders, even more than that, right? That depends on the order. The more the sensitive and more the relatable the problem is with any kind of disorder, the more it will be termed on first. Okay. So here comes how to write the tentative diagnosis in a very relatable and uh, authentic and according to your professional manner. All right. So according to the DSM-5 TR, being a psychologist or any other psychiatric consultant, we have to follow two manuals. For the psychiatrist, they have to follow ICD, right? And its manual is currently 11. And as a clinical psychologist, we have to follow DSM-5 TR, right? So in case of DSM-5 TR, for example, we got a diagnosis of a person that is the major depressive disorder, all right? So first of all, what you are going to do? First would be the particular code of the disorder that is being mentioned in the DSM-5 TR is going to be write down. All right. Then in the bracket or the small brackets, you are going to write down the particular ICD or the psychiatric code of that particular disorder. All right. After that, you are going to write the complete name of that appropriate disorder that is relatable to that particular patient, all right? Then comes the nature of the specifiers. In some disorders, specifiers are regarding the term, regarding the severities. In some of them, they are regarding the episodes, right? Either it's the first episodes or is it going to be a remission, right? So nature of specifier would be mentioned here. For example, in case of conversion disorder, diagnosis is a bit different kind of scenario because specifiers are a bit different. All right. Then comes the episode. What kind of episode the patient is currently having? Is it about the current first episode or is it going on? All right. Then comes this term. Term is actually about, you can say, that particular problem if that particular problem is being relatively the first one to appear. For example, in case of bipolar disorder, if the problem is more appropriately currently just a manic episode, right? So you have to mention if it's currently manic episode right now, all right? You have to mention it there. So the term is consistently patronized with the episode as well. Then comes the severity of the problem. Severity is always mentioned in case if it's being mentioned in the specifier in the DSM-5 TR about that particular disorder. Secondly, if you have performed a complete diagnostic test of that particular disorder on the patient and it has a proper cutoff score for that severity, then you have to mention the severity of that particular problem for that particular patient. All right, got it? Then comes if the current problem is being remissioned or it's just appeared to be new. All right. Then most probably this is the point where students actually got confused and they don't know how to write it down and where do we got this particular thing. That is the V code and Z code. These are particularly relatable to the, you can say it, factorizing the problem, all right? Writing a complete picture of the factors that have contributed in the problem, right? So V codes or Z codes are basically about the social factors, or you can say the interpersonal factors of that particular person. They have a complete checklist in the content list of the DSM-5 GR. Whenever you open it, there is a complete list in the end of that content list where you can actually understand how to mention V code or Z code for the person. They have a complete categories for that and complete coding for that. All right. So for your understanding and better learning, let's just open the DSM-5 GR. All right. Okay. So, okay, by chance, we're having disorder relatively being opened. That is substance medication induced bipolar and related disorder. All right. If I'm not going to talk about the complete diagnostic requirements and the criteria of the this particular disorder, let's just overview it. All right. A person is being using some kind of medication or some kind of substance that have induced the symptoms that are similar to the bipolar disorder or any other relatable disorder. All right. That would be stayed here. If that particular substance or that particular medication have been found in the laboratory examination in the past history of the medicine that they have these particular side effects or contributions in causing those particular problems, then you would have to mention that here in this list. All right. So this is the particular criteria for the whole scenario. Now it comes to the ICD. All right. So the ICD code for that is not relatively so mentioned here, but they state that induced bipolar disorder are indicated in the current uh, coding table. All right. So here is that particular coding. First, you have to mention the code of the DSM, right? Then you have to actually code according to the, first of all, the substance here, and then according to the severity level, right? With mild use, if it's alcohol, and with the mild use, then you have to write in those brackets F10.14, all right? If with the moderate or severe use of the alcohol, then it's going to be 10.24, right? So then comes that we talked about here, nature of the specifiers. We talked about that, right? That with alcohol use, right? Here comes the specifier of alcohol, then comma, then the episode with the onset during the intoxication, or is either it's due to the onset of the withdrawal or with after the medication use, whatever is it, you are going to mention that here with the episode. If the episode is mild, severe, or whatever the severity level is, we're going to mention that here, right? Then comes its V codes and Z codes. So let's just make it clear as well. So V codes and Z codes. Okay. Let's just open the contents list first and we will learn about it as well. If you guys have any kind of question till now, you can ask me. Yeah, here is it for you that we had discussed. Name of the disorder, the nature of the specifiers. Nature of the specifier are here. If it's mild, moderate, severe, profound, whatever it is, right? Then if the current episode is the first one or is it the recurrent episode, you have to mention that too in that episode, right? Then comes the severity, right? And if it's about a remission, you have to write it down as well, looking at that particular specifier. Specifiers or any other relatable terms we have discussed in the diagnosis performer here, you're not going to actually write down that in your own form, whatever you want. No, it's not like that. There is proper standardized things in the manual in the DSM-5. You have to get it aware from there and then you have to write it down. All right. So let's just go forward to the V codes and Z codes. This is the content list and let's just skim it out. So this is it. See, all right. So this is the complete list here for either kind of V codes or Z codes. All right. If the client has a factor of the suicidal behavior or non-suicidal self-injury that's are being specified here in different points, you have to make sure to write down according to that. All right. Then comes if the client had a factor of the sexual abuse in his childhood, or even if the child has some kind of sexual abuse history, then you have to clearly mention that according to these particular criteria. All right. First of all, child abuse, sexual abuse confirmed. And if it has an initial encounter recently, you have to write down this particular thing. All right. If it has a subsequent encounter over the period of time, then you have to also mention that here, right? In your diagnosis. I have seen a lot of case studies, a lot of students doing this mistake and they don't know how to write it down. And even when we used to ask them, why didn't you write your V codes or Z codes in your diagnosis? They would be like, we don't know how to write that down. We never have studied that. So there is a complete list for you to understand that. All right. If there is a violence or sexual abuse from your spouse or from your partner, partner can be any person you are being living with, right? So you have to make sure to actually study that as well. If that abuse is physical, that includes the violence, we have seen it. Then the psychological, then if the abuse is from a very non-partner person, a very, the less close person, you have to make sure to write down as well, right? Then the relational problems have been marked here. If you have any kind of housing problem, economic issues, if the client has been having some kind of environmental circumstances or some personal issues, you also have to write that down. Even in case of any healthcare encounters recently, right? Any genetic issues, any sexual counseling or dietary counseling, you have to mention that in your B code or Z, right? These are the very basic key points for you. Even here, even students don't know that malingering have a complete Z code in DSM. Okay, so we talked about the diagnosis today. Then comes the mental status examination. we talked yesterday that what basically mental status examination is. Let's just tone it apart to understand it. Mental means your mind. Status means your cognitive status. And examination means you are testing that, you are assessing that particular patient about his current mental state, his cognitive state. All right, by using a very projective way. Mental status examination is not an assessment tool, but a projective technique to assess that person very well by an observation, right? So, if you guys don't understand me in any case, just let me know, all right? Even you can embark your voice here. I have no issue with that. All right. So, what are the basic key points you have to cover whenever you are doing any kind of mental status examination in any kind of patient? That is his general appearance. You have to get aware if the client is wearing appropriate dress, his culturally appropriate dress according to his season, according to his gender, right? Is he wearing glasses and the inside or in a very dark room? That's seem absurd, and you have to observe those things. All right, his behavior, his self-care is very important to be noted there. All right, you have to find out that if the client is very much cooperative towards you. All right, what is actually his manner overall? What if he is hesitant, he's slow in talk? All right, what is overall image of the patient for you? Okay, then comes the second point, that is his gestures. General appearance also regards your the client's gestures towards you, his behavior, his gestures, his manners. All right, his mobility. How did he? Obviously, when he walked into your clinic, when he walked into your room, and then towards the chair, he walked right. So, what was his walking like? Was it slowed? Was it unbalanced? Was he walking properly? Was he taking the complete steps properly? All right. So you have to note that down. Okay. Then comes the second component in that inquiry, that is talk form. Right. I'm not talking about the content of the talk that has been recorded in your therapeutic sessions. You're not talking about the talk content. You're talking about his form, all right? Form of his talk. That is, if the client is being uttering something during the talk, right? Was his talk being a bit slurred, or is he talking very excessively or very little? All right. Is he talking spontaneously, or you have to make him answer to every question, right? Whether his talk was coherent with your question, all right? Whether he was actually relevant towards the topic, or he was just moving around. For example, let me give you an example for that, for the better understanding for your concept. In case of manic episode, mostly for the bipolar disorder, especially in case of females, when you would encounter, you would learn to know if you ask them, how was your day today? Rather than answering it's well or it's not good, or um that particular person do that, that particular person do that. No, he would be circumstantial. He would be talking all about other things, but not about that particular things you have asked about. He would be like, it was good, but I did that, I had that talk with that particular person, and he or she is not actually talking about that particular question you have asked about. She's talking. She's talking, right? She's not having some kind of slurred speech. She's not uttering, but her talk is excessively circumstantial, means circumference. Circumference is that particular boundary around the circle, right? So she's not talking about the center of the circle you have asked for. She's talking about the surrounding boundary of the circle. That is called the circum uh, circumstance. All right. So circumstantiality is very much important to be highlighted in case of talk. Then comes another component in case of a recording or inquiring in the mental status examination is the mood of the patient. You don't need to actually ask him about his mood. Either you can, but you have to make sure to understand his appearance. You have to make sure to objectively make the impression of his mood state. All right. You can ask him, it's not so big deal, but you have to make sure to record his mood. Either he's being a bit agitated today, either he's being so low today. You have to make sure about that to record it. All right. Now, it's not actually the sheet, or you can say, as we talked about the standard pattern of the history taking, it's not that. These are actually the inquiring components you have to make sure to learn in your mind whenever you are recording the mental status examination of the person. These are those particular questions, those particular inquiries you have to go through while recording the mental status examination. All right. We are not actually moving towards the mental status examination right now. So the next is the thought. In case of thought, I'm not talking about what actually he's thinking. No, I'm not talking about that. We are going to talk about the form of the thought. Either his thought is, having some kind of abnormalities, all right? Form of the patient's thought. Either he's having the, lack of association in his thoughts, right? Sometimes people would be reporting that I don't know, it's like some kind of jungle in my thoughts, right? Then they even sometimes say, I used to think that, and then their other mentioned thought would be totally different from their prior. There would find no connection between those particular thoughts, right? Then comes the flow. Flow is the second component in case of thought recording that actually, you know, uh, be about, you can say, either his thought flow is rapid or it's being so retarded that you would feel like, all right, it's thinking slow, right? So then comes the content. In case of content, you have to know if those particular thoughts are having some kind of obsessions or delusions or misinterpretations. You have to make sure about the nature of the content of the thought. I'm not talking about that particular content. I'm talking about its nature. All right. You have to mark that down in case of any abnormality found. All right. Then comes the perception. All right. In case of perception, we actually have to make sure to find out if the patient actually experiencing some kind of a perceptual abnormality. All right. For example, if there is a perception without any stimulus, there's no stimulus there, but the person is perceiving that, then it would be hallucination, right? It can be tactile, it can be um, auditory, it can be visual, right? So these could be any kind. So in that case, the source, the reality, the manner of reception, or the content, those all particular circumstances of the experience are important and it must be reported in detail, right? So inquiring it whether to these experiences occur at that particular time or for instance, right? You have to mark that down because these are indications for you. These are your observations. Then comes another, that is the obsession. So obsessional thoughts or you can say impulses or acts are very much important to thought because you have to ask them if they are being felt like to be, uh, unresistant to react on certain particular thoughts, right? Or they feel preoccupied with certain kind of behaviors or thoughts, right? So you have to find out their persistent uh, distressing factors, or you can say the triggers around them, right? Or does he able to recognize them so inappropriate, right? Because doing that particular thing over the period of time and repeatedly made a person realize that there is something wrong. Why am I doing that? Why is it being so observed with me to do all this um, again and again and again? It's like a chain, and I'm being stuck there, right? So those particular obsessional thoughts have any relationship to their emotional state is very important to be understand, right? For example, his repetitive actions like washing hands or reassuring himself about some kind of thing. So that reassurance is meant to be remarked. Okay. Then comes another thing, that is the orientation. We talked about it yesterday in our previous lecture, that recording the patient answer to his own name, his address, his place where he is. Why is it important for him to be here? What time is it today? Is it morning, evening? All right. What is he doing here? These are very much important to record because it will help you out to know what level of reality contact he is having right now. All right. Then comes attention and concentration. You have to note down that whether his attention can easily be aroused or as being so sustained, right? Does he concentrate in whatever task you have asked him to do? All right. Is he easily distracted, or does he appear very much preoccupied with that particular task? Like he's been into it, right? So to test his concentration, you can actually ask him to tell the days of the week or the month, all right? And you make him reverse the order, all right? Because in case of reversing that order, you are actually making him concentrate and pay attention to that particular problem, right? So it would help you out to understand his attention and concentration over the period of time. Then comes another component, that is the memory. How to test the memory of the client, right? So recording the patient or the client's success or failure in your register and retaining it. And, you can ask him to recall his number, his address, or any kind of data after 2 to 5 minutes again. All right. You can ask him, all right, you have told me about what you used to do, but can you please tell me again? I think I have missed that part, right? So you can ask him again, but you would have to record that quietly as well, right? Give him some kind of digits to repeat, right? So I'm telling you some kind of activities alongside to make you understand what you can do during that particular session, during that observation over the period of time during taking the history or even after that to assess the person's mental state, his mind, what is actually being stuck there. You can have access to that thing, and that access can be drawn here because you are performing some kind of activities along the side. You are indulging the patient in the session. So it would also help you out in rapidability. You are making him work. So you are making him work out in the distress as well, right? So then comes the another thing, that is the general information. Why is it so important to ask him some kind of general questions? Because you are actually grasping about, according to the patient's educational level, to actually help to make him familiarize about the current affairs, about, his aptitude. You can also access whether a person is being very well aware about the surroundings. You can ask him whether it was raining today. All right. Um, what do you think? What actually the month is right now? All right. Do you feel cold today? All right. Okay. You can ask him. All right. Which party is the ruling party right now? Do you know about it? Actually, I'm being a bit out, so I didn't know. Can you tell me about that? If a person is from the political science and he don't know, then you have to mark that down because he's been cut off from that particular side of himself, right? And it's being a very interesting thing for you. And where did you get that interesting thing? From this mental status examination component, right? Then comes another thing that is the insight or judgment. So, in case of insight and judgment, you have to ask about his awareness, his attitude towards his present state, right? Does he regard it as an illness or any physical or psychological, or whether he just think that this particular treatment is just required, right? You can ask him in certain kind of manners. For example, do you think there is anything that matter with you right now? All right. Is there anything you think is troubling you and that have made you came here? All right. What do you think that is? Right. Could it be a nervous condition or something? What do you think is the cause? All right. Do you know why did you need to come to the hospital or the clinic today? Right. What are you doing? You are accessing his orientation. You are accessing his insight, his judgment, right? About his problem, about his mental status, and as well as you are observing the client. So this was the brief manner. And now, after the break of 10 minutes, we are going to discuss the mental status examination sheet here. We will be going through this, and then just it will be the remaining lecture today, right? So, meeting will be end soon. So, let's just re-continue after 10 minutes. If you guys have any question till now, you can just ask me. Anyone having any question? Those